So thank you to Sama and the organizers for the invitation. By this time, you're all seasoned Zoom loggers, but I'm also aware of the ability to multitask. Your smell receptors are probably sampling Sunday dinner by now, and family sounds may be distracting. I'll try to be concise yet challenging. This is a basic set out of what I'll be discussing, just some general practice comments. And I've divided it up into before COVID, and then the COVID disruption that we've all endured, and after COVID, the new normal. And then we'll go into some principles of office-based surgery and anesthesia. So it's about 12 years ago that I was invited to collate and edit the SAMA edition, the September edition of the Continuing Medical Education SAMA publication. The QR code to the URL can be scanned to access the website address. I will also place the URL in the chat, and this QR code will come up a few times in the discussion, in the slides. So why office-based surgery? That was the question we asked 12 years ago. Basically, the healthcare system was in quite a mess. Too expensive, underperforming, unaccountable, and then the disparity of state versus private and national health insurance looming. One of the notions people have that if it's broken but profitable, don't fix it. In South Africa, we take it even further by breaking it down until there's nothing left, and then wonder how we're ever going to fix it. The spend has been disproportionate on high-ticket items like medical specialists, diagnostic machines, surgical robots, and complex interventions. And there was an inevitability of disruption. To help purchasers and patients spend less on healthcare, to make delivery systems more efficient and productive. Robert Pearl coined the 3 pillars of productivity that would require major changes. Rethinking of reimbursement, restructuring our hospitals, and rebalancing healthcare delivery. In the United States, from about the 80s, there was a significant rise in outpatient surgery being performed, with an attempt then to drive down inpatient admissions and surgery. This saw then outpatient surgery happening more frequently, but also the development of freestanding outpatient surgical centers and in doctor or physician office-based settings. Many of these, or most of these, were actually owned by physicians or in collaboration with other corporates. This is a picture of in the 1970s, one of the early outpatient surgical centers in America. The attempts to improve productivity in a traditional company culture would be to consider bigger is better and vertical integration. But on the contrary, some businesses discovered that small is beautiful, focus is fabulous. One could leverage an integrated systems perspective, investing in teams, outsourcing, and in technology and information. So the focus should be on treatment in the optimal point of care, looking at outcomes rather than the process, and putting patients first. But hospitals and scheme administrators collude on pricing and volume, deciding where patients will have to go and what may be used, or else face massive co-payments, so-called high deductible plans, if they ventured out of network. The patients have relationships with their doctors. The book by Rob Pearl that is trending now, Uncaring, How the Culture of Medicine Kills Doctors and Patients. As doctors, we're not really trained or equipped to handle these moral, financial, and ethical issues. Pearl asks doctors to evolve, to confront their own conditioning, and to collaborate on solutions. We must regain recognition for our sacrifice and skills. Doctors will have to accept change, even if it means that they make less money and enjoy less independence. Instead of claiming the right to perform a range of procedures, they will have to acknowledge the data that shows specializing in one procedure results in better outcomes for patients, though it may not be as satisfying or fulfilling for the doctor. And then came COVID. The theme of this conference has been how we managing this COVID crisis. And it's actually been a disaster. We've been struggling all along with RPL, Certificate of Need, National Health Insurance, health market inquiries, PIA and Apopia. And then this virus came and actually just devastated everything. We're trying to cope with it as wave and wave of COVID come along, but the havoc and death that has been wreaked is but small compared to the tsunami of financial hardship that we are going to have to face in the ensuing years. So as we think of reopening or trying to develop some semblance of a new normal, we've again started looking at outpatient surgery, outpatient surgical procedures. These are procedures carried out in the doctor's office or even in outpatient departments. There are very few actual ambulatory surgical centers in South Africa, and we all know about day surgery and day surgery procedures. In America, it's common if a patient needs to stay over to have an extended recovery arrangement for overnight stay and even limited care accommodation, an adjacent hotel or hostel to accommodate patients where professional health care is available on a call basis after the procedures. Basically, office-based surgery can be divided into complexity according to the anesthesia that is required and the procedures. So the well-known minor surgery performed under topical or local anesthesia in the rooms would be level 1. The moment one starts using mild to moderate sedation and analgesia, it then is called level 2. And once we slip into deep sedation or unconscious sedation or general anesthetic, that would be regarded as level 3. In terms of the scope of practice, 50 years ago in the South African Medical Journal, there were already published copies of regulations governing unattached operating theatre units. This picture didn't come out in high quality, but basically the procedures that we could consider would be surgical procedures such as biopsies, breast surgery, anorectal conditions, laparoscopic procedures, and some orthopedic manipulations and procedures. Endoscopic procedures are commonly performed in the office-based setting. Plastic and reconstructive surgery can also be done in the office-based setting and often moved into that area due to cost issues. Quite a few ENT procedures and ophthalmology, such as cataracts, can be done in the office-based setting. Gynecological procedures, those for infertility, dental and maxillofacial procedures. So the scope is wide, and the abilities to perform in office-based environment is enhanced as new developments happen. Just a graph to show in America how the range of procedures look. Gastrointestinal endoscopy is a commonly performed procedure, so also cataract, ophthalmology, pain management, and then a smattering of other procedures. The skills for performance and management of office-based surgery are not adequately taught in our university undergraduate or residency programs. Additional private mentorship and training is mandatory. The choice of sedation and anesthetic is the responsibility of the surgeon and or the anesthetist. There should be adequate knowledge and experience of a procedure, the equipment needed, as well as indications, contraindications, complications, all of these before attempting any surgery. Of course, adequate informed consent on the risks and benefits must be confirmed. Standard or universal precautions against infections, now very well known with the COVID epidemic and the way we have to protect ourselves, our environment, and our clients. And also the facilities need to be well appointed, not just a little cottage surgery performed in a corner of a poorly resourced office. Recovery areas and recovery discharge should be very well worked out. We need to understand our equipment, and it should be decent equipment. And then having performed these procedures, there's always a lot of things that need to be cleaned, reprocessed, and sterilized, with obvious production of hazardous waste that needs to be managed. So safety is paramount. This includes things such as the building, electrical safety, staff safety. In terms of monitoring, capnography is commonly required in any advanced procedural sedation and an analgesia. There should be adequate arrangements to rescue any complication or adverse event, including fire and building hazards, with precise updated transfer arrangements if we were to have to move the patient to an intensive care or to a hospital. So there is an advantage of the place of service being in close proximity or in the precincts of a hospital. But some hospitals don't allow office-based surgery and anesthesia in their rooms. This is maybe for safety concerns or even competition reasons. The expanded concept of office-based surgery and anesthesia may seem obvious. The financial incentives are there, and the patients certainly demand it. But it's financially onerous under the current general economic downturn, the poor rand exchange rates, and below cost returns in terms of reimbursement. So before embarking on this path, one should perform a feasibility study and market analysis. Expert advice should be sought. Doctor comfort and a one-stop shop practice is fraught with financial and legal constraints. Most funders refuse to reimburse out-of-hospital costs adequately. Even if they do provide pre-authorization for the procedure, they may not pay for the procedure-related consumables, and these may have to come out of the day-to-day savings accounts or out of pocket. However, some have seen the light and encourage office-based procedures. Quality of care standards and accreditation are poorly addressed in South Africa. The regulations governing unattached operating theatre units are lengthy and onerous. They do not really address the practical and legal issues of office-based surgery and endoscopy and the modern concept of ambulatory surgical centers. The medico-legal indemnity insurers, such as MPS, have warned that they may not be able to assist or provide indemnity cover for procedures performed in unregistered attached theatres where complaints or claims to emanate. Most of our office-based surgery in South Africa is currently undertaken in doctors' rooms where no formal accreditation or licensing is held. And this clearly exposes practitioners and the owner of the facility to numerous legal and ethical risks. So legislation and governance processes are either antiquated or lacking. There are disadvantages of office-based surgery, and one of these being that we may have to use lower budget, cheaper equipment. To me, a disadvantage is that innovation tends to be a lonely place. And big business tends to want to gobble up everything and be in charge. They even want to employ us. So there tends to be a hell of a fight and push back against this tendency, particularly if you're trying to develop your office-based surgery. Another disadvantage is that it may stifle innovation, research, and technology transfer. These days, we know of developments in artificial intelligence, machine learning, deep learning. For example, in colonoscopy and screening colonoscopy, artificial intelligence has been invoked to improve and actually automate detection of polyps in the colon, and even characterize these polyps automatically, a so-called optical biopsy. AI could allow detection of flat or subtle adenomas that would not be picked up under usual white light or lower quality endoscopes. We may even not have to send away our polyps, having had computer-aided diagnosis applied to polyps. Nevertheless, there are compelling benefits to consider an office-based or office procedure. The time savings are great. We all know that hospital surgery schedules can be a problem, and delays are a fact of life in theatre. In the office, the doctor or surgeon is in control with limited downtime and less delays. Cost savings are obvious. The additional massive costs tacked onto hospital surgery, the operating theatre fee, anesthesiology, and medication fees, these can all add up quickly and be around about 70% more expensive compared to the office-based environment. It could even also be less exposure to nosocomial hospital-acquired infection. So it's all about quality and striving for clinical outcomes and patient satisfaction, an envelope we need to push now that COVID is allowing us to open up again a little bit. So thank you for your attention. The QR codes, this is my email address, and this is the link to the URL, which will also be on the chat. Thank you very much.